Hello and welcome to the Columbus Metropolitan Club. My name is LaCory Meadows and I am a member of the CMC Board of Trustees. I also serve as the Director of OSU Extension here in Franklin County. It's such a pleasure to see everyone today. So let's get going with today's forum. Today's forum in our Healthy Community series is presented by Ohio Health with additional support from Mount Carmel Health Systems as well as Battelle. Each are represented here by many friends and associates, so won't you please help me to thank them for their sponsorship. So we all know that healthcare is quite expensive. And of course, one important but elusive goal is lowering cost. At the same time, we want to ensure that spending is adequate and reaches those who are most vulnerable as well as those who are most in need. This is where today's health dashboard provides some context. So let's hear from our experts. We have Ohio State Representative of District 24 and Policy Research Director at Kennell and Associates, Allison Russo. We also have with us the Executive Director at the Ohio Commission on Minority Health, Angela Dawson. And Franklin County Public Health Commissioner, Joe Mazzola. And last but certainly not least, our host, who is the president of the Health Policy Institute of Ohio, Amy Rohling McGee. Amy will start us off with a preview of the 2019 dashboard and then lead the conversation. Amy, the podium is yours.
Thank you, and thank you to the Columbus Metropolitan Club for inviting us all here today to discuss how Ohio performs on health and healthcare spending. The timing of today's forum is serendipitous. April is National Minority Health Month, and this week is National Public Health Week. About 6 years ago, the staff and board of the Health Policy Institute of Ohio started asking these questions. How does Ohio compare to other states, and are we moving the needle on key health outcomes? Are the health policies adopted by our state leaders, including investments in state tax dollars, sustainable and contributing to improvements in health? We knew that there were a number of existing scorecards that shed light on where Ohio stands compared to other states on health. But what we realized that there was no single source measuring both our state's performance on health and health outcomes and healthcare spending, what we refer to as health value. Since both of these components are equally important, we decided to work with stakeholders across our state to create the Health Value Dashboard. The dashboard examines Ohio's rank and trend performance compared to other states on a composite measure of health value, as well as 100 specific metrics. In creating the dashboard, we knew it was important to include all of the factors that influence our health. And what I mean by that is that researchers have estimated that only about 20% of our overall health, of the modifiable factors that contribute to our health, are related to clinical factors, meaning when we go to see a doctor or other provider, or when we're using the hospital system. 50% of our overall health is shaped by non-clinical factors, which are often referred to as the social drivers of health or the social determinants of health, such as access to quality education and to housing. About 30% of our health is related to our behaviors or our choices. So think about this for a second. While access to high-quality clinical care is critically important if you're sick, if you have a chronic health condition, if you experience an accident or injury, most of what makes us healthy or unhealthy is related to opportunities and barriers that we have outside of healthcare settings. That's why, in addition to measuring access to care, and performance of our healthcare and public health systems, the dashboard also includes rankings of Ohio's social, economic, and physical environments. Tomorrow, we're releasing the 3rd edition of the Health Value Dashboard. In the latest edition, and you're the first to hear this, Ohio ranks 28th for healthcare spending and 43rd for population health, with a ranking of 46th on health value. This means that Ohioans are living less healthy lives and spending more on health care than people in most other states. Ohio ranks in the bottom quartile on 30% of the metrics, and the top quartile in only 5% of the metrics. Why do we rank so poorly? We've identified 3 main reasons. First, too many Ohioans are left behind. Not all Ohioans have the same opportunity to be healthy. The dashboard highlights several disparities and inequities. Many Ohioans face barriers to being healthy due to unequal access to post-secondary education, a job that pays a self-sufficient income, quality affordable housing, and increased exposure to adverse childhood experiences, violence, racism, and discrimination. We can't improve health value without first addressing these barriers. Second, our resources are out of balance. Ohio's healthcare spending is mostly on costly downstream care to treat health problems. This is largely due to many missed upstream opportunities to prevent or better manage injury, illness, or disability for thousands of Ohioans. And finally, addiction is holding Ohioans back. Addiction is a complex problem at the root of many of Ohio's greatest health challenges, including drug overdose deaths, smoking, unemployment, and incarceration. Ohio's leaders have worked hard to address our drug overdose crisis, but critical gaps remain. While Ohio's problems are serious and can seem overwhelming, the good news is that there are evidence-informed strategies that can improve outcomes, control healthcare spending, and reduce disparities. In the dashboard, we highlight 9 prioritized specific strategies that policymakers and others can use as a starting point. These strategies support 3 policy goals. The first goal is to create opportunities for all Ohio children to thrive. The second goal is to invest upstream in transportation, in employment, and in housing. And then finally, we need to do more to build and sustain a high-quality addiction prevention, treatment, and recovery system. We look forward to hearing from our panelists today as they discuss ways that we can achieve these goals and improve health value in Ohio. So to begin, my first question is focused on that first policy goal related to creating environments for all Ohio children to thrive. There seems to be bipartisan agreement on this goal, that investing in children will improve health outcomes over the long term. So what policies should be prioritized by Ohio's lawmakers for consideration on this topic?
So I will start, since I am the panelist that is in the Statehouse at the moment. So I think certainly when we've looked at what Governor DeWine has put forth in his budget proposal, we see incredible, I think unprecedented, at least in recent years, investment in things like public health and prevention, and as well as around children's health. And I am very encouraged by that, and I think that's a great direction for us to go as a state. If you look at some of those policy priorities, one, of course, that's getting quite a bit of attention is certainly around the issue of infant mortality. That is an issue that we need to address in a very aggressive way. But I would also point out that, making sure that we're not looking at some of these issues in a very strict lens So when we're talking about infant mortality, we also need to be talking about our maternal mortality. We need to talk about taking care of pregnant women between pregnancies and before they get pregnant. And also, as you so eloquently stated, when we think about policy priorities, remembering that if you really want to have an impact on healthcare, whether we're talking about children or adults, we need to stop looking outside of the four walls of where we deliver healthcare. We have to start looking at those investments in some of these social determinants that will also have a very real impact on healthcare, improving healthcare outcomes. So for example, right now in the General Assembly, we will be discussing and deciding how we're going to fund our public schools in the state. And thinking about that in terms of healthcare, because the investment that we make in public schools is also going to have an impact on healthcare. We just passed a transportation budget that had investment in public transit. That is also a healthcare issue, because when we have good public transit systems, we're getting people and children and parents to their doctor's appointments. When we talk about improving the economic stability of families, you cannot have healthy children if you don't also have parents who are able to provide good housing, have stable jobs that offer health coverage, and they have the ability to get their children to their prevention appointments. So I think making sure that we are looking at many of these issues that we typically don't think of as healthcare issues through that healthcare lens is important, and we should be doing that.
And thank you, Representative Russo. I think one of the things that many of us do not look at oftentimes is the fact of where we are ranked in this state. Overall, Ohio ranks 40th in infant mortality, and I couldn't agree more. We have to do something that is less strict. But we rank 49th in the nation for African-American infant mortality. And so we really, in order to move that proverbial needle, we really have to begin investing in strategies. We talk about evidence-based strategies, but we must be able to drill down to ask the question, evidence-based for who? And so if the strategies that we are investing in have not clearly shown improvements in African-American infant mortality, in efforts and models that look at addressing the social determinants of health. It is very important to address prenatal care and postpartum care in our models, but we also must connect women to housing and transportation, and we must do so in a mechanism that is evidence-based, that is also peer-reviewed, and has a national strategy. It's so important that we don't limit ourselves to what we've always done, because over the last 3 decades, Ohio has continued to invest its infant mortality strategies for high-risk pregnant women in clinical care. And so if we always do what we've always done, we're going to get what we've always gotten. And it's so important that we begin to ask that critical question. There are models in Ohio that are effective. The commission is proud to have implemented such a model that has a return on investment, but moreover, Buckeye Health has done a study to demonstrate that return on investment and risk reduction. So I agree, we can't be strict, but we also have to make sure that what we are implementing on the ground is going to be effective for populations also that bear the burden of death, disease, and disability.
Well, thank you, Representative Russo and Director Dawson. I think I'd like to pose the next question to Joe, although others can feel free to chime in. One of the roles of public health entities is planning in collaboration with others in the community that care about health as well. And especially when we talk about addressing these social drivers, what opportunities do you think there are for greater collaboration with other partners in our community?
Sure. Thank you so much for letting me be a part of this conversation. So what we've seen here in Franklin County is a really nice example of how we need to think about our public health planning differently. And so what we've done here locally is we've convened a group of stakeholders that really represent those different domains of social determinants to inform our public health planning. So when we put forward our community health improvement plan last year, it wasn't the traditional public health partners. It was partners within realms of education and transportation and economic development, so that we could really connect with their perspectives on how we can really align our work with theirs. And so as I think about what's happening at the state level and the value dashboard, I think there's an opportunity for us to, we talk about alignment of the state health improvement plan and the community health improvement plan, and that's really a great starting point. But I think our next step is really about aligning those social determinants and that planning at the local and state level. So when the representative talks about the policy initiatives that are happening at the State House, I think we need to think about locally, what do those mean for us, and how can we inform our strategic planning around that? And then at the state level, I would recommend that we look at how can our transportation, and it's so great to hear about the investment in public transportation, but how can our transportation plans align with our economic development plans, which align with our education plans, which ultimately improve our health. So I think we've taken a nice step forward in terms of collaboration and in terms of a planning standpoint, but now I think it's really about how do we do what we're doing here in Franklin County and align that with the state and of course our other counties across the state of Ohio. So again, for us, we are really wanting to invest more effort in terms of aligning what we're doing in public health with those domains, and then hopefully connect what we're doing here locally with the state.
One of the components of the health value dashboard, which will be available on our website tomorrow, are a series of equity profiles where we look at disaggregated data regarding gaps in outcomes. And I'm wondering what our panelists' thoughts are related to opportunities for both the public and the private sector to work to address these health disparities in a more intentional and comprehensive way.
Certainly. We are glad and want to say to everyone, happy Minority Health Month. Minority Health Month was created by the Commission on Minority Health. A lot of people don't realize that. It's now a national celebration. But when we look at opportunities for public-private partnerships, this is one of the things that I think deserves the greatest thinkers in the room and the greatest thinkers in our state. And I think some of them are gathered here today. We know that when we look at the issue of social determinants of health, that's when we usually hit a wall in our planning process and we go, wait a minute, I'm not responsible for that. Am I responsible for that? And so what we want to be able to do is look at realistic policy strategies that can get at the social determinants of health. When we look at housing, when we look at employment, when we look at education, here are the opportunities for us to draw the line. It's policies that put these practices into place, and it will take policies to remove and improve those practices. So when we look at what other states have done, so other states have increased their funding for post-secondary education, which has resulted in improvements in income levels and what we can earn. Other states have put multiple models on the ground, and that really are not just downstream, but are also upstream and midstream. When we look at the area of housing, other states have really looked at how do we make safe, affordable housing more available for those at-risk populations? How do we incentivize employers to offer child care at work? So these are some of the opportunities where we can work together across systems. How do we look at hospital systems and their ability to improve their efforts around cultural competency training or implicit bias training? How do we look at small pilot projects that are demonstrated in the Everyone Health Project or in the Robert Wood Johnson's Finding Answers Project? These things can be very difficult, but if we combine our equity efforts and our quality improvement efforts within our systems, then we can make progress. But this is why we invite partners to the table. I would love to partner with organizations to help them as we guide through finding the answers in small pilot project opportunities. There are a lot of opportunities and improvement is possible. So we may be 46 today, but by looking at the challenges of population health, we can improve our health value. What are other states doing that Ohio is not doing? And those are the places that we can begin.
Yeah, I was just going to say as well, when we think about, and I absolutely agree with everything that you have said, but also making sure that when we are making these decisions from a policymaker perspective, that we've got diverse voices at the table. Because I have experienced that also to be a problem. So we're talking about infant mortality, and we don't have an African American at the table in that roundtable discussion. And whether that's bringing these multiple players to the table to have those discussions, to listen to input, or even who's in elected office. I will say that we've had quite a bit of focus from some of my colleagues because they're bringing their own experiences from their own communities, and some of them from their own personal experiences as well. So making sure that we are being inclusive when we're having these conversations about disparities. And also, I think about the way that we train our healthcare providers as well, and making sure that we have diversity in the healthcare providers, whether that be physicians or nurses who are taking care of patients. And that's not just racial diversity, but that's also economic diversity, because we know that a big part of health inequity is also in the delivery of care and how we interact and providers interact with patients, and that unconscious bias that happens. And so to change that, we need to have more diverse providers as well delivering care.
So I'll just offer one quick thought on that. I think when we talk about disparities, we need to talk about data. And what we've really have been focused on is incorporating non-traditional data sets in with our public health initiatives. So for us, if we're really wanting to address these disparities, we have to include data sets that maybe we typically haven't. And so, for example, including housing data within our public health planning, and really getting more actionable real-time data sets as well. So it really is the most important part to identifying where those disparities exist, so that we can do better in terms of putting more equitable strategies and resources to address those public health challenges.
I think as well, the use of geospatial mapping has really moved us forward in helping policymakers and system decision makers to see exactly where the lay of the land is. As is a practice in state funding, we tend to do scattershot funding, so we're just going to give everybody a little bit. But really what the research has shown is when we do geospatial mapping and begin to look at where are the problems, where is diabetes most impacted, how is that correlated with other comorbidities such as heart disease, and let us get the resources exactly into the communities that are bearing that brunt of that disability, of that disease or disability. It also presents a picture for us to be able to show our policymakers, here's where the problem is. Are our resources going to the areas that are most affected? And I think the use of disaggregated data also by population. Oftentimes, Asian American Pacific Islanders are seen as the healthy minority. It's because we group everyone together. So you will not see the differences or the significant disparities that they experience between the refugee population and the immigrant population. And so we need to demand and insist upon oversampling of data, disaggregated data by subpopulation, so that we can begin to get at preventative strategies that really provide cost savings for our state. We cannot wait till downstream to treat diabetes and dialysis and amputation. But we really have to move upstream and make chronic disease self-management or prevention available for all populations so that we can begin to look at cost savings and improved health outcomes.
Thank you, thank you. So as I said earlier, addiction is one of Ohio's greatest health challenges. And I can imagine that most of us here are aware of that challenge as it pertains to our drug overdose rate. But one surprising fact may be the fact that we also rank very poorly on adult smoking rate and the rate of children exposed to secondhand smoke. One of the things that we did in terms of the examination of all the metrics in the dashboard is we ran a correlation analysis of health value and other factors, looking at all other states in the country. The strongest correlation to health value is adult smoking rate. All of the states that are in the top quartile for health value have much lower adult smoking rates than Ohio. So I'm wondering what our panelists' thoughts are related to efforts to address addiction as a whole, but also addiction to illicit drugs or misused drugs and nicotine. What efforts have you seen as successful, in particular here locally, and where do we still have work, both locally or at the state level, to address these challenges?
So I'll offer a few thoughts there. I think with tobacco, if I could start there, tobacco is one of those issues for us that is extremely frustrating because we know what works with tobacco control. We know we know the amount of investment that we need, and we know how to and where to invest those dollars. We've seen the success in previous efforts back in the early 2000s, late 2000s. We saw tobacco use decline here in the state of Ohio because we had significant investments there. Recently, we've not been able to sustain those investments, and unfortunately, we've seen those tobacco use rates rise. And then we've also just recently, there was a panel this year 2 weeks ago regarding the Juul epidemic and e-cigarettes. And so the tobacco industry is changing. And so I think what I would suggest is that we need to look at addiction and tobacco in terms of a long, it's a long-term game. And it's not a, yes, we can invest significant dollars, see the decrease, and then expect that the problem's going to go away. We need to continue to invest in prevention, in cessation, and in policy change to create those environments that would really help reinforce the fact that we value the health of our community. Things like tobacco to 21 policies, things like tobacco-free parks, tobacco-free schools. So the issue of tobacco for us, we're really focused on that here in Franklin County. We know that our adult smoking rate continues to be higher than the state average. We have a tobacco cessation grant, so it's something we're continuing to invest in. Further on the more broad on the addiction issue, I'll just speak just very briefly. With our opiate addiction plan here in Franklin County, we put that in place in 2017. Many of the individuals in this room helped put that together. And over the last 2 years, we've realized it needs to not just be an opiate plan, it needs to be an addiction plan. And so our partners at Adam H. and other partners across Franklin County, with their leadership, really recognizing that we need to think about addiction more holistically. So, you know, addiction is certainly a public health priority and and really is front and center in terms of our public health strategies. But really, we need to think about addiction long-term, and we need to think about addiction more holistically.
So I will add to that, this issue of prevention and investing in prevention. I think one of the challenges as a lawmaker who has to make decisions about resources and what to invest in, one of the challenges that we face with many of these issues, and I agree in addiction, we have to be thinking long-term about this, is we're thinking in 2-year terms in the General Assembly because we have a 2-year budget cycle. For many of these prevention investments, we don't see return on that investment for 10, 20 years, and that's a challenge for many people to think about. The money that you are spending now, you are not going to see the impact of that for a decade or 2 decades. And so I think that I would challenge not only myself, but my colleagues to rethink how we are investing our money and making those decisions, because you're absolutely correct. If we're making the the investment at the end of the addiction cycle, that's not a smart investment. We know that the return on investment is going to be so much larger, and it makes so much more sense, and ultimately we're going to be saving money in the long term if we invest early in preventing, whether we're talking about addiction, whether we're talking about chronic disease prevention, a whole host of issues. We have to change our perspective on how we view those investments and resources.
I couldn't agree more, Representative Russo. We really have to focus on short-term fixes, but long-term change. And that becomes difficult because you're trying to say to your constituents, see what I did? And we are limited by term, but those prevention investments are what are going to get us to the long haul. One of the realities for addiction, when we address addiction, especially within the political environment, there's this tendency to pick the drug of choice or the drug of the month. And I couldn't agree more, Joe, that we really have to have an overarching addiction plan. And that plan has to be sensitized that every population has to have access to treatment. We have to have a more robust behavioral health system. We have to fund that system so that treatment is on demand. We have to make sure that even within the prison system, that treatment is available across populations. That access to treatment and a robust behavioral health system combined with prevention activities is really what's going to help us. But the strategies have to be tailored to the populations. So it's easy to want to do a very slick ad campaign, but if it's not tailored from a cultural and linguistic perspective to populations throughout Ohio, we're going to fall short again. And so there's a tendency to say if we just do a general approach, it'll reach more people. But in fact, the opposite is true. Tailored approaches, the research has demonstrated, really have a greater impact within both treatment strategies and prevention efforts. So that is definitely something that we have to move forward to and consider that other states that have made progress in reduction of smoking have also considered legalizing the age of tobacco use at the age of 21.
And we're going to move to audience questions here just in a few minutes. So the microphone's over there. Please go ahead and queue up. I'm just going to touch on a few final thoughts before we get to the questions. On your tables, I think many of you have already found it, but there's a one-page back front dashboard snapshot. As I mentioned earlier, the full dashboard with all of the metrics and analysis will be available tomorrow on our website, which is hpio.net. This document provides you with some of the highlights or lowlights, as it may seem. While our health value rank is low, there are many evidence-informed opportunities we can pursue. And I really liked what Director Dawson said about evidence-based for whom. We like to use the word evidence-informed because the evidence does point us in the right direction as to what works. Often, though, the approaches need to be tailored to a particular community, a particular setting, to a particular target population. What we've done, though, with those 9 prioritized strategies is look at the research evidence and then also consider what strategies could improve health, reduce spending, and reduce disparities. We have a number of sources we use to find that data. All of that information will be available or is available in the full dashboard. And you'll note that we've highlighted strategies related to children, those related to addressing the social drivers of health, and then those related to addiction prevention and creating a more comprehensive strategy with adequate treatment capacity. It's important, I think, to emphasize that we want the dashboard to be a catalyst for improvement, not simply a grade card for where we are now. We've learned a lot over the years since we've been producing the dashboard about what policymakers are looking for. They don't just need the data. They need to know why and what they can do about it. And that's what we've sought to emphasize in the dashboard. We know that Ohio's rank is not strong. We perform poorly, but we also know that improvement is possible. We can look at what other states have done. We can look at the research evidence, and we know that we all have roles to play to achieve better outcomes. With that, and before I move on, I just want to thank the HPIO team. Raise your hands. It's a tremendous work effort, and we have an amazing staff at our organization. I'm also pointing them out that if you have any specific questions afterwards, you can just go to them, because they are subject matter experts on the dashboard, are very knowledgeable about the sources and all of the elements of the product. So let's go ahead and start with our first question.
I found the discussion today quite fascinating and very directly related to the discussion 2 weeks ago on affordable housing. The commonality is systems thinking was involved. We have to understand how the different parts interact, and that cause and effect, as one of our panelists noted, are separated by time and space. This is a higher level of thinking than what often occurs. My question is, what is necessary, or how can we take steps to help elected officials at the state and local level have a better understanding and appreciation of systems thinking?
Mm-hmm. And I did forget one housekeeping detail, and I'm so glad that you adhered to the rule that all of the comments should be questions. So no editorializing. Phrase your comments as a question, which you did.
Did I do okay?
Yes, yes, thank you. You're obviously a veteran CMC person. All right. Go ahead. So the question was related to systems thinking and how we need more systemic approaches. The gentleman commented on how a couple of weeks ago there was a forum on housing here. I know that there was one related to tobacco a few weeks ago, but these are complex issues that touch on multiple systems. How can we make sure that policymakers are taking a systemic approach to addressing these?
Well, I will start with that. I view it as my personal mission at the Statehouse to bring that perspective. Unfortunately, I come to the table with public health training in background as well as work experience. So you're absolutely right, because often when we talk about these issues, most often they're talked about within these very strict lanes. And I would say that again, my goal is, and I view this as part of my goal in being in an elected office, is to work with my colleagues to make sure that when we're talking about things like public transit and education and economic development, that I'm talking about those as also healthcare issues. Or when we're talking about housing is such a big, important piece of this, that we're viewing that as also an education and a healthcare issue. I mean, to me, you're absolutely right. You cannot disentangle how all of these issues interact with each other, and you can't simply target healthcare spending and clinical services and expect to get the outcomes that we hope to achieve. So I think it's having more diverse voices and experiences at the table in elected office. We've got a pediatrician now who is in the General Assembly who also has a public health background. So we've been two champions for many of those issues in our first term. And, making sure that we're bringing the right people to the table as well to inform both us and our colleagues on how these systems really interact.
So I would just offer one more thought on that. I think it's really our job here locally to connect these conversations. So when we have transportation and housing and education, and we have those system kinds of conversations, I think it's our job here to connect the dots so that when education officials are talking to state representatives and state senators and other policymakers, that health is part of that conversation. So that's what we're trying to do here locally, and I've made it a point, so everything that we do at the health department, we're making sure that we are trying to get to those conversations here locally. So we were invited to the poverty conversation. We're part of the transportation conversation as we're able to. So we need to inform those discussions so that they can then carry that message to our policymakers, I think, in a more cohesive way.
Thank you for what is an excellent question. The systemic view is so critical for the elimination of disparities, and especially for racial and ethnic populations and the achievement of equity. Because structural racism is managed and controlled within systems, if we do not put a systemic lens, then we can't get at the infrastructure that undergirds the distribution of the essential resources, housing, food, transportation. I want you to just think 15 years ago for the healthcare systems in the room. Think about what you allocated for transportation. Very little, but you began to draw the dot and make the connection to say, oh, if they can't get to the appointment, it's going to impact health outcomes, it will impact the bottom line. And transportation was once thought of as that's the patient's responsibility. But now, you will now see health systems who are fully engaged in non-emergency medical transportation because they connected the dot, if you will, to make sure that as a system we provide access, not just to health care, but also to quality health care. Thank you for your question.
Matt.
Hi, I'm Matt Habash from the Food Bank, and I probably couldn't have had a better lead into my question. If I could adopt something from our old Wendy's promotion, where's the beef? Where does food fit into this? We take it for granted. And I submit, if you don't eat, none of this matters. And so we take that all for granted in this process. We know we're 69 million missing meals in this county annually for people below 200% of poverty. So my question is, how do we get food addressed in this so that people have access to healthy food? How to look at SNAP as good public health policy instead of an entitlement we love to hate? And how do we look at WIC as a real strong strategy with less than a 50% participation rate to address infant mortality?
So for those of you who don't know, Matt Habash, the director of the Mid-Ohio Food Bank, was just awarded the Population Health Award given by Columbus CEO last week for his work related to food insecurity. We do agree that addressing food insecurity is a necessary and important strategy to achieving health value. In fact, in the disparity or in the equity profiles that are in the dashboard, one of the metrics we look at is food deserts. And in particular for low-income Ohioans, there's a little over 3 times likelihood of living in a food desert if you're lower income than if you're not. So we know that this is an area of significant disparity in our state that does need to be addressed in order to get to health value. What do our panelists have to say on that?
So definitely, food access is essential. One of the things that we know that we have to change the paradigm that food access is only an issue in a rural area. And so we really have to change the paradigm that food deserts can absolutely exist within urban areas. When you combine the limited food access with a lack of transportation, with a lack of income, food is a basic for health. You cannot be healthy if you do not eat healthy food. And so part of our strategies are to work with our local offices of minority health that are in 6 of the largest cities in Ohio on food access policies, ensuring that all populations have access to food, but it must start, as Mr. Habash has said, in policy decisions, in increasing the ability for individuals to purchase food and to have access to healthy food. So that is a policy decision that must be made.
I don't have much more to add to that except to say I absolutely agree. One of my other passions is this issue of food insecurity. But again, I think it's thinking from a systemic approach outside of sort of the traditional lens of how we look at food insecurity. Some of the work that I've done in the past is really focused on, how do we get food to children in schools so that when they leave school, they usually have good food sources while they're at school, but when they leave school in the evenings and on the weekends and over long holidays, how do we address those needs as well? And again, that comes back to thinking about when we're investing in public education, we're also investing in some of the solutions as well. So I absolutely agree, and did not mean to leave out food because it is important, and certainly the quality of the food that we're eating and making sure we have more fresh food available to our population is essential.
Yes, we're hosting a forum tomorrow, our dashboard release forum down at the Mid-Ohio Food Bank. If you want to attend, well, it might be too late, sorry, Alana, but at the end of that, we'll be touring the Mid-Ohio Food Bank too. Let's get to our next question.
I'll be quick. Matt, he stole my beautiful thunder because that is at the heart of what I believe. Food is medicine. My name is Kirin Otsmal-Warapa. I'm a physician, and I focus on family medicine and lifestyle medicine. And I just wanted to tell you first, thank you for addressing the fact that there are a lot of things we do that are necessary but not sufficient. And so you're trying to tackle them. I'm going to piggyback on Matt real quickly. Are you aware of the data that speaks to the fact that that is probably the variable that if you change it, you do get an immediate return on your dollar investment? And specifically, it's great to see a diabetic who's no longer on meds within weeks because they started eating plants or just eating healthy. So I'm curious if you have that information to share with your colleagues, and if not, how can we get that to you?
You can email it to
me. I think we'd all appreciate any additional information.
And I asked that. Oh, I'm sorry. Go ahead.
Go ahead.
No, I asked that because it's sometimes the conversation centers as a moral issue or the science is there, but there's a strong economic return on investment when you eat healthy food. So I was just curious if that's really the thought for your colleagues at the policy level or in other ways?
Well, and one of the things that I'm always struck by is that when there are opportunities for people to get access to healthy food, like I know Columbus Public Health has had these like farmers markets, there's been other efforts to bring fresh food to low-income neighborhoods, and there'll be lines around the block of people wanting this food. So to your point, Dr. Warapa, it's not always a choice issue. It's having the opportunity, and then also the opportunity to spend the time preparing the food as well, and the knowledge of how to prepare fresh fruits and vegetables. But number one is the access to the fresh fruits and vegetables. Thank you, Dr. Robinson. Yes.
Hi, my name is Pam Cobb. I'm also a family practitioner. Saw you speak to the OAFP the other day, Amy. Thank you so much for all the wonderful work that you do. When you were talking, I was thinking about the most vulnerable population that we're talking about here, and that is the fetus. By that I mean, if we would look at infant mortality, and I would say also childhood morbidity as well, if we would look at that, it impacts every single one, from food to education of the mother as well as the child, to transportation, all of that. If you could solve that problem, a lot of this would fall in place. Not next year, not 10 years from now, but 20 years from now, I would bet that all of your statistics on everything, addiction, it would all be improving because that little baby is affected by every single one of those things. They're the most vulnerable. They're the canary in the coal mine. So I like the KISS principle. I'm like, okay, I just got a lot to think about, but if I could focus on one thing, that if I was sitting in your seat, Allison, and you represent my district, by the way, that I would be, okay, I've got so many dollars, so where do I want to put my focus, my attention? Where do I want to get to be the expert in? Because we can't, none of us can be the expert in all of this, but we can pick our little piece and say, I'm going to take that piece and I'm going to work with that piece. So that's all I had to say. Oh, the question, you wanted a question. The question is, I'm so sorry. The question is, what can we do to reduce infant mortality, or what is being done right now? I know Mount Carmel had some efforts when I worked with Heart of Ohio, but what is out there right now?
Certainly, I would be more than happy to share. The Commission on Minority Health invested in the early 90s in a model called the Pathway Certified community hub model. And that model was then replicated in Toledo, Ohio. That model is now used in 10 other states and in 6 areas in Ohio. And you're right, we are seeing evidence and outcomes in the short run of what we are seeing. This is a nationally certified, evidence-based, pay-for-performance model that is ran by certified community health workers connecting high-risk women to social determinant of health resources as well as prenatal care and postpartum care. And so just in this preliminary data from 2018, we are seeing where 5 of our 6 hubs have improved preterm birth over their respective county averages for African American singleton births. We are also seeing that 6 out of our 6 hubs are also seeing improvements in low birth weight for African American singleton births. So structured programs that are implemented to populations at the level of need are showing improvement and cost savings. And so this is also being replicated across the state, and the commission is looking to bring that to scale in the state of Ohio. So there are things that are being done that are specifically focused on the populations that are bearing the brunt of those disabilities. And this model can be spread across Ohio. We also have the Ohio Equity Institutes that are across the state of Ohio, as well as OCPIM, which is that overarching body that looks at infant mortality as a whole.
What's that?
Questions? We want to go through them real quickly. 2 more quick.
Okay, great. Thank you, sir.
Hi, my name's David Hography, and I'm a concerned Ohioan. I guess I think the statistics that you shared are shocking, and I'm bothered by that as a nation and as a person who lives in Ohio. My question, I guess, relates to personal accountability and responsibility, and how are we as a culture feeding and clothing and housing those that need it, because that is our duty of care. But at the same time, there is a level of responsibility that I believe is lacking in terms of it's not that complicated to try to eat healthy, moderate amounts, to exercise, to take care of each other, to make good decisions when it comes to alcohol and tobacco. So I guess I want to talk about that, because that's the front end. Everything else is treatment and rehab, and I understand that. But I think at the heart of it, we've got some issues about how we really hold each other accountable to be healthy citizens.
Yes. So if I could just say something really quick. So as I said earlier, our health is influenced by our choices and our behaviors. That comprises about 20% of our overall health. We do have a role to play. However, it's also related to those opportunities we have to be healthy, and I often think of my own self, the fact that I live in a neighborhood where I can go running in the morning and not worry about getting shot. I have access to healthy food, and just remembering that not everyone has those opportunities. But yes, of course, we all do have a responsibility to make healthy choices and to develop a culture that is conducive to those choices. Representative Russo.
Well, I just want to take this as a moment, throwing out that 20% statistics, but also to say that we are the only state in the country that does not have health education standards. And we need standards for our students, and often this conversation revolves around, or gets very hyper-focused on sex education, but health education is holistic health education. It's talking about healthy behaviors and healthy eating and nutrition. It's talking about addiction prevention. It's talking about how do we navigate our complex healthcare system. And I view that as just as important as teaching our children about financial literacy, how to apply to school or how to apply to jobs afterwards. We also need to be talking about health education in an evidence-based way.
All right, let's get to that last question.
All right, so my name is Nidhi. I'm an optometrist and also a student at OSU's Public Health, College of Public Health. A lot of the solutions you've been proposing, some of them fall into the systems thinking, broad-based solutions, and some of them fall into this targeted, disaggregated approach. And to me, those seem very dichotomous. And so I'm wondering, what are other states doing that respects both fields, the systems-based approach as well as the disaggregated, personalized approach? And why aren't we doing it?
Excellent question. Those are policy choices that are made, but we can change the choice. So policymakers can absolutely make this case for the requirement of health departments at the state level, local level, to disaggregate data. It means that there will be an investment in oversampling so that we can ensure that subpopulations are appropriately reflected in the data. That gives us opportunities. You cannot imagine how frustrating it is to say we only have data by Black, white, and other. How many of us know other doesn't get an allocation, other doesn't get a funding line? And so we really have to make a policy choice that everyone counts, but if you're not counted, it's unlikely that you'll be included.
So what are the policies that other states are doing that we aren't doing?
And so one of the things that happened in Senate Bill 332, which was related to the Infant Mortality Commission report, was the requirement for disaggregation of data for the Department of Health on birth statistics at the lowest geographic level and racial level possible. But that was for infant mortality. That can be replicated across the board in other areas, but it means a strategic, intentional focus on making sure that everyone counts.
Thank you. I would just round that out by saying, you know, when we look at what other countries are doing and the investments that they are making, we spend in the United States more on healthcare and get poorer outcomes than other countries who spend less on healthcare and get better outcomes. But if you look at how they're spending, they're also flipping in that they are spending more on social services and those things that drive those social determinants than what they spend on healthcare, whereas we have that flipped in the United States. So I think that as states, when we're having these conversations about resources, that we flip in our minds, and that's going to be a difficult thing, that's a big ask, but we have to flip how we think of our spending and what we are spending on, because those social services are extremely important if we want to have the impact on healthcare and reduce our overall healthcare spending in the long term.
Thank you for your question.
Excellent. Yes. Well, I really hope that all of you truly enjoyed today's forum. I found it to be quite insightful. Please join me in thanking our sponsors, Ohio Health, Mount Carmel Health Systems, and Battelle, as well as our speakers, Amy Rohling McGee, Allison Russo, Angela Dawson, Joe Mazzola. And thanks to all of you for being here. We look forward to seeing you again next week.